5, 8, 10 if you're planning your morning, and then I entertain questions, or you've got to leave and run, then you're set. I live in Brainerd. We've been there 22 years now, and same house, 4 kids, no dog. And I retired in full-time practice there 4 years ago. I've been covering different medical centers since then on a part-time basis. That's my intent. And the reason why I'm here is I was covering the Buffalo Line Clinic for the last couple of years when they lost their part-time person. They've been able to hire now a full-time coverage there. And then Virginia Piper and administration here invited me to come out here and start a more eccentric, I should say, oncology practice. Not saying that we would be in at Abbott or St. Cloud, but trying to center patient care more than everything gets farmed out. And I have a lot of experience in doing that. We moved to Brainerd in 1990, and at that time there was MOPA was up in Brainerd one day a week. And then when I retired 4 years ago, we had 3 oncologists, full-time nurse practitioner, radiation therapy, Joint Commission on Cancer certification, tumor registry, the whole 9 yards. So, although Moore isn't really the size of Brainerd, it's, it's just the same challenge as Brainerd, except on a little smaller scale. I'm from Chicago originally, went to Northwestern University of Illinois, did my residency and fellowship at Mayo. And why Brainerd? Well, I fish a lot. And we like small towns even like you do, otherwise you wouldn't be here. Okay. The reason why I chose this topic is because it still is the #1 reason why I see blood patients. And so I really geared it toward experienced, knowledgeable practitioners who deal with this entity on a regular basis, because there's some things that I believe I can add that is a value that enhances your practice. I have a brother who's an ENT surgeon. He says, well, I probably do more removable earwax than anything else. And it sounds kind of silly, but iron deficiency really is still a bread and butter type of issue. And there's a lot of cracks that I see because I see a lot of referrals for that in Buffalo. I see patients at the St. Cloud VA, men, and I see a lot of it there. And so it's amazing how much falls through to my lab. If you want to interrupt, to clarify a question, you interrupt me right now or during your talk, otherwise we can chat after I'm done in about 20 minutes or so. So what's the typical iron deficiency? We all know what that is. It's a low MCD, they're anemic, they're serum ferritin, iron studies are low. You get a gastroscopy or colonoscopy, they have colon cancer or peptic ulcer disease. That's the thing we all think of, okay? Just like we think of what's a Republican, what's a Democrat. Well, there's an idea or image, but really, typical picture doesn't really conform very often. Only 20% of patients with iron deficiency anemia end up with this type of picture, and the rest fall into this gray never land. So I'm going to preview what we're going to talk about today. We're going to talk about history and symptoms, atypical causes, a distinction from anemia of chronic disease, distinction from other microcytic anemias, evaluation of the small bowel. This entity that some of you may not be aware of is called idiopathic anemia of aging, and the most important thing, issues of iron replacement therapy. There's a lot more than is often thought of what is meant by optimal iron replacement therapy. Briefly, what are the kind of things that I look for when I see a patient who may have iron deficiency? The #1 thing that I look for that is missed is pica. Pica is the perverted appetite for substances not fit as food. In Minnesota, it's typically ice. So a person comes to you with ice craving, that's my clue that they're iron deficient. Now, if you're a black woman in Mississippi, then it's river clay. Other parts of the country, it could be dirt or paper, but in this part of the country, it's typically ice. Restless leg syndrome, in other words, paresthesias, you know, whether legs at breast, and then the leg, of course, if you move it in activity, the paresthesias get better. That's the classic restless leg syndrome, associated with other conditions, but we see that with iron deficiency. Gastric bypass surgery, that's obvious, but it's surprising how inobvious it is sometimes when that patient presents with iron deficiency, just by history. And then finally, we know about gluten enteropathy and celiac disease, but we really seldom recognize the fact that there's a strong neuropsychiatric component to that illness. And I have opportunity to see those patients, and so it's amazing. I ask them how much better they feel. They don't talk about their anemia symptoms. They just tell us how much better they are in terms of depression, paresthesias, and other neuropsych symptoms. On physical findings, these are findings that can be seen in things besides iron deficiency, but cheilitis or angular stomatitis. Other nutritional deficiencies can cause atrophic glossitis. It's flattening of the tongue, the shininess where you lose those folds. And then a condition which, I've seen 2 new patients with hereditary hemorrhagic telangiectasia in Buffalo in the last 2.5 years. Buffalo's, 10,000 people, Morris 3,600. So, I always think in terms of what are you likely to see. But these patients have telangiectasias, or these malformed blood vessels, all over, all from just above the lip. They have it in the lung, they can get in the brain, and that's where they get in big trouble. But typically they present with iron deficiency from GI blood loss. This is the best study that I found to present the idea as it presents to the practitioner, okay? Because we can talk about iron deficiency from an encyclopedia, or from Harrison's Internal Medicine, or from Up to Date, but it doesn't talk to you as a practitioner the spectrum of iron deficiency. So this is an Italian hematology clinic. 668 consecutive patients referred for anything remotely related to iron deficiency. We all are familiar with these criteria: a mild anemia, a small red cells, and a blood ferritin or iron level less than 30. And then he called out all these patients where you obviously know it's what it is. Someone who's bleeding heavily from menstrual periods, someone who has an obvious rectal cancer, someone who's been ill for a long time. They eliminate all that easy stuff. And what you got is the pure iron deficiency without any simple, obvious cause. And you'll all see that in your practice. So we're going to concentrate on those 71 patients in this 2-year study. So these patients all underwent what you usually do, okay? They usually undergo colonoscopy, EGD. All of them, however, had gastric and duodenal biopsies, okay? And the summary is that in 1 in 6 people, we didn't find a cause. That's usually where I end up with them, okay? Just 3 in 8, we find a cause related to bleeding. That's the typical stuff you think of. But what you don't realize, of course, until now, is that, in fact, most causes of iron deficiency are associated with diseases that are not associated with bleeding. And that's the key here. And then, of course, there's a concordance rate of 8% where we find 2 causes or more. So we'll talk about the easy one first. So don't forget, there's 71 patients, 37% cause associated with bleeding, and these are easy because we think of this all the time. Colon cancer is the most common, but it's still only 1 in 7 with iron deficiency. Peptic ulcer is 1 in 10. Hiatal hernias with linear erosions, and I'll show you a picture. Malformed blood vessels or ectasia in several people, gastric cancer, colored polyps, and proteases are miscellaneous. So the biggies for associated bleeding is colon cancer, peptic ulcers, and hiatal hernias. That's a gimme. You all know that. Now, How do you diagnose it? I look at a chest x-ray. So I look at whether they've had a chest film. And they say hilar hernia. We don't think much of hilar hernias. The criteria, usually if it's a hilar hernia is 2 centimeters or less, it won't cause iron deficiency. Typically, hilar hernias that extend into the chest about 5 centimeters or 2 inches are the ones that are likely to be associated with linear erosions and iron deficiency. So that's the criteria. In this patient, you see the gastric bubble shadow above the diaphragm. And this is a patient who was at high risk for hilar hernia. Now, not everyone with hilar hernias have iron deficiency, but this is the kind of patient that you automatically think of right away. And endoscopically, what you see this little red mark in the gastric folds right at where the stomach is in the diaphragm. So the stomach moves back and forth above and below the diaphragm at that nexus or the crux, the fulcrum. It's thought that like a napkin ring, the edges of the stomach are compressed through the diaphragm and then open up, and with repeated trauma, they develop these lines in the stomach fold that bleed, and eventually it causes iron deficiency. Now, this is the most important slide in terms of the non-GI blood causes, because it really affects the primary care provider and the endoscopist. Okay, because what we find here is that most patients with iron deficiency don't have causes commonly associated with GI blood loss. That's the most important thing. So when you see somebody, you know, it's not called iron deficiency. If you did, you're going to move to the house. The house is going to win, because it's going to need usually this general category we call atopic gastritis. You know, the GI people call it differently these days because they divide it into different causes. But basically, causes of gastritis where there's insufficient acid production by the stomach or stomach injury. So non-steroidals, bile reflux that you can see from the duodenum, alcohol. And the symptom of low acid production is elevated gastrin levels, low B12 levels like pernicious anemia, and then autoimmune causes to atopic gastritis, including anti-parietal cell and nutrition factor antibodies. This requires really, your endoscopist to do biopsies in everybody. How many times have I seen someone with iron deficiency, normal EGD, and colonoscopy, and then no biopsy? And so I do H. pylori or a urea nitrogen breath test that's positive. It's unbelievably common. Okay, that's the key here. Is Dr. Fleming here? Okay, well, so your surgeons who go to endoscopies and Dr. Fleming and people who get sent to Minnesota GI, they really all need gastric and duodenal biopsies, because that's where the money is in iron deficiency anemia. But as the primary care provider, as a consultant, I have to be really careful history for these issues, and I have to be willing to look for H. pylori disease if it wasn't done. Usually I see the patient after endoscopy, and I look at the report. It says, stomach negative, no biopsy. Well, I still suspect, statistically speaking, that it's going to be one of these two entities. And of course, the one that you can be a real hero is you look for celiac disease. So you get your tissue drench contaminase or endomycin antibody studies. And of course, of the 71 patients, 4 of them, or 6%, had celiac disease. This is an Italian study, but they're Northern Europeans. And you see celiac disease in non-Europeans too, but perhaps not to some extent. So H. pylori, well, I graduated from medical school in 1977, so you can figure how old I am roughly. And back in 1988, everyone was laughing about ulcer disease caused by a bacteria. It was proposed by some doctors in Australia. We thought they'd been out in the outback too long. And as we know now, it's really the causative agent for much peptic ulcer disease. But back then, it was just laughable. And I remember those days, because I was there then. Celiac disease, well, of course, under the microscope, the villi you see in the bowel becomes flattened, and so you see this grossly, the villi flattened, where they should be more robust in the upper slide here. Atypical causes of iron deficiency, blood donation. And I see this a lot at the VA, but we see this in general practice. We have to ask, have you donated blood? And you'd be amazed how many people have been donating blood until, say, 4 or 5 years ago. And that's your tip-off for people who have iron deficiency. Why did they have iron deficiency? They were depleted, they got a little bit over the cliff, and they lived over there, and then one day they fell off the cliff and never relapsed. It could be other causes, but that's a very important clue. Gastric bypass surgery, small bowel angiodysplasia. We'll have some slides later about small bowel studies, how to use a small bowel radiology to help you. This is pretty common. Non-steroidals. If someone takes ibuprofen or Aleve, you expect to see gastropathy. But sometimes you see the injury to the mucosa downstream in the small bowel. Just like we've heard of potassium chloride tablets causing ulceration downstream. We see this with non-steroidals. You don't see it unless you look for it, okay? And then this rare condition we'll talk about later called paroxysmal nocturnal hemoglobinuria. That's Lyme disease, so you don't have to worry about that. But we talk about blood donation. Now, gastric bypass. The reason why people get iron deficient with gastric bypass is, number one, this is a typical room-wide gastric bypass. If the surgeon makes a really small pouch, like they're supposed to, then the acid-producing portion of the stomach doesn't get to mix with food or iron. And you need acid to absorb iron. And then the prime iron-absorbing segment of the bowel is the duodenum and the very first part of the jejunum. So if the bypass portion of the bowel is long, if the pouch is small, and if this portion is long, then that patient is a prime candidate for iron deficiency. So I'd say about 30 to 40% of your gastric bypass patients eventually develop iron deficiency. And for most of them, it's permanent. So they have to learn to deal with it. And some of them can handle with oral iron, others need parental iron. But if the pouch is small, and this segment, small bowel segment, is long, then everything they take dietary-wise bypasses the acid they need to absorb the iron and the absorption surface in the proximal small bowel. The tangled blood vessels, we call them ectasia or angiodysplasia, bowel AV malformations. And trust me, it's just a little blister that will do it. That will cause severe iron deficiency. They keep losing a little bit of blood all the time. Your stool test will miss it. And it's incredible when I think about what real problems will cause so much clinical manifestations. The most common area for angiodysplasia is really distal small bowel, ileum, or proximal colon. So that's an area that's often missed. Well, what's this? This my son caught a muskie. This is Lake Alexander near Motley earlier this summer. Well, catching a muskie is like for a hematologist than to find someone with paroxysmal nocturnal hemoglobinuria. So it's that feeling. It's like, I got one. So this is 47 inches, and this is with someone else's boat. We don't have a ranger, so PNH is a sort of a hematologist disease. What it is, it's a myeloproliferative syndrome. It's a bone marrow disorder where the red cells are sensitive to complement. So they lyse red cells all the time, and they develop iron deficiency. They develop coffee-colored urine. They have other problems, and they can die of a leukemia-like situation. I just use that general term. So it's a serious disease, but there's treatment for it. I had to get this in here. So. I got a little farmer's tan today. We were fishing Mille Lacs last week, and so we're big into fishing. Iron deficiency differential diagnosis, I really only want to emphasize one area. That's in red. Everyone knows this. Everyone knows iron deficiency, low serum iron, elevated TIBC, total iron binding capacity, low serum ferritin. That's easy. We all know that. And really most of us are pretty comfortable with anemia of chronic disease, where the serum iron is low, but the ferritin is normal or elevated, and they have some form of inflammation. The CRP or C-reactive protein is elevated or saturate, or they've applied something. And you can just tell clinically someone's got chronic issues. You're mildly anemic, you get this iron study, you know they might have chronic disease. But the trick is, how do you identify iron deficiency anemia in the setting of anemia of chronic disease? We get both, and that's pretty common, because who doesn't have a lot of old people in their practice? Raise their hand, because we all do, all right? And so when you have an old practice, there's a lot of chronic disease, so we get a lot of anemia of chronic disease. And these people also develop iron deficiency. So what's the trick? The trick is, there's a couple clues. Number one, if you get a normal serum ferritin in these people, then you use the 1/3 rule. So for instance, if a man has a serum ferritin of 60, which is normal, okay, and they have mild anemia, and their serum iron is low, and their TIBC is normal or low, and it could be anemia of chronic disease. If their ferritin is just 60 for a man, you divide that by 1/3, or multiply by 1/3, and their quote-unquote adjusted serum ferritin is 20, then they probably have iron deficiency. Okay. Another clue, of course, they have inflammatory markers, but you probably already know that. And the other thing, they have what's called an elevated serum transferrin receptor, which you can find in your EPIC order entry. Okay. And that is something that you see with iron deficiency. You can see with other things too. And sometimes it gets complicated. But the point is that use the 1/3 rule for ferritin. So if a woman's ferritin is 50, which is normal for a woman, and she's got anemia of chronic disease, she probably also has iron deficiency in addition. That's the take-home lesson from this slide. I don't want to get too much into this, except to point out one thing. There are other causes of microcytic anemia. This is sort of a hematology kind of diagnosis. And I want to emphasize just this one thing here. Why do people with thalassemia, the most common thing is beta thalassemia, why do they have normal or elevated serum ferritins when you first see them? They've all had unsuccessful trials of iron therapy. So they all have sky-high ferritins. Everyone's tried to get their hemoglobin up with iron. And of course, their disease is not related to iron deficiency. So of course, all that is microcytic is not iron deficiency. In fact, people with thalassemia often present with MCVs 65, 70, really, really low. That's a tip-off that they probably don't have iron deficiency, probably something else. That's the only take-home lesson of this slide. I want to get into the rest of this. You know, it's 8 o'clock in the morning. Small bowel imaging. Okay. This is a typical single contrast small bowel polyp. If you order a small bowel polyp, this is what you see, and it's a relatively gross evaluation of the small bowel. So you're looking for small bowel disease when the EGD and colonoscopy are negative. Nowadays, and that can be done here. Nowadays, the younger radiologists do CT small bowel enterography, which is a little more sensitive. Okay, and you can see the bowel folds better, and you can see a little more detail. But you can miss stuff. The older experienced radiologists, my generation, we did what was called, I'm not radiologists, I'm sorry, but we did what's called small bowel enteroclysis. Now what is that? That's where the radiologist inserts a tube down in the stomach, intubates the duodenum, and there's usually a balloon here that inflates. And then they insert, they instill contrast. But what happens, because there's tubes here and there's a bulb here that inflates, the stomach juices don't mix with the contrast, and they're much higher resolution study. Most younger radiologists don't So this is a sort of a really good procedure, but it's not as used as often as it used to be. And the reason why these are important studies is because nowadays we have a way to evaluate the small bowel. We have the swallow camera. And what they do with this swallow camera, it's about that size. It's a little bigger than a Bactrim pill, if you've ever seen our Cetera pill. It's a big horse pill. And the patient carries around a purse-like device, a little computer which receives all the data, transcutaneously, and then it's interpreted usually by a GI person. And we look for small bowel disease. Now, if you're thinking about small bowel disease, the first three procedures, this procedure, interoclysis, interrography, and the typical small bowel follow-through, will only pick up stuff you can see grossly. And the last study, that pill cam study or interoscopy with a camera, will pick up stuff you see in the bowel wall. You would never pick up these procedures. But you'd never go to a pill study first. And the reason why is people have done that, and if someone has, say, a small bowel tumor, that pill gets stuck. And then GI people lose their camera, and the patient is really PO'd at you. So we always do a preliminary study, a small bowel follow-through, interrography, less so intercolitis, because we want to rule out a gross obstruction. And then we would consider this pill camera study. Am I suggesting that a primary care provider do this? Well, not necessarily. It all depends on your comfort level, your experience. Sometimes we talk about it in the hallway, and then you go ahead and do it. But anyways, the small bowel represents the majority of problems that are missed in that Rome study without evaluating that organ, the small bowel. Okay, we got a couple more slides and we'll be concluded. I threw this in. This has nothing to do with iron deficiency, but usually in a small town, like I know, we have a lot of old people. Young people go to the cities, the oldest stay back in Mora or Brainerd or whatever, okay? And we see a lot of mild anemia in older people, 11.5, 12, 12.3 grams of hemoglobin. And we worry about them. We do a diligent evaluation. You all know what that is like. Well, there is an entity that's kind of growing in sort of prominence. And these are people that we call anemia of aging. And what happens is that we found that if we compare these people to people who are just like them at their age or not anemic, they often have lower erythropoietin levels than other normal controls or people where the cause of anemia has already been identified. And so we think what's happening is somehow they don't sense their anemia like they're supposed to. And so they don't put out the erythropoietin from the kidney like they're supposed to. It's sort of a thermostat issue. It's just like if the thermostat here says 70 and it feels like 60 in this room in January. We also know that in both older men and women, those who have relatively lower testosterone levels, men and women, compared to their age-matched controls, have a higher risk of anemia when they have lower free and total testosterone. So if I have a man who's, say, 81, whose hemoglobin is 11.6 or 10.9, and we do a diligent evaluation. We look for iron deficiency, we evaluate the small bowel. They may have gone through a bone marrow to rule out a myelodysplastic syndrome. And then I get a total of free testosterone that's really, really low. And then I get a PSA to rule out prostate cancer because what I'm thinking about is giving them some testosterone. And all of a sudden, a little testosterone, the hemoglobin's recovered. So I'm not saying that this is a therapeutic modality of giving testosterone. It's really, in most people, even 80-year-olds that can tolerate hemoglobin 11.8, and you have to really balance. But the fact of the matter is that there is probably an anemia of aging, which is what I call physiological, related to the aging process, and perhaps sort of an inaccurate thermostat in the body. Iron replacement issue. This is really important. So I talked about small bowel problems, about anemia, chronic disease, and iron deficiency diagnosis. This is the most important take-home lesson. We'll summarize it at the end. There's non-compliance issues. Control GI symptoms. We're talking about malabsorption of iron. PPIs, and how it relates to iron therapy. Control trial iron supplementation, parental iron therapy. That's really important. Okay, ideal therapy is 325 milligrams 4 times a day, and the key is, despite what the pharmacists say on their sheets, it's taken on an empty stomach where there's acid, because you need acid to absorb iron. So you want to take it an hour before meals or 2 hours afterwards and at bedtime. That's the ideal way, but you know, some of your patients can't tolerate it. Okay, my daughter who's from cross country can't tolerate it. So you have to modify things. So of course what you do is you modify by taking the iron a little closer before meals, or a little closer after meal. Okay, so there's a little less acid, but they can tolerate it, all right? Or you modify the number of daily doses. So you tell Mrs. Jones, well, take 3 months supply, but take it until you're done, which means 6 months, and she takes it twice a day rather than 4 times a day. It requires some modulation, all right? So that's a typical form of therapy. If you give these milder forms of wax, matrix, or slow absorption iron preparations, they don't work because they don't get absorbed where the body can absorb it. They're designed to be absorbed farther downstream. They cause fewer side effects because they don't get absorbed. Remember, the area where the bowel absorbs the iron is the proximal small bowel, duodenum, the proximal jejunum. So if they get absorbed in the ileum, you're not doing the patient any favor. So these are really important. Now, some patients, they can take it any time of day and they'll do just fine. But it's the ones that don't seem to respond that give you trouble. They call you back, and you're wondering, what happened? Did she not take it, or what happened? And so, in the best case scenario, this is usually the reason why it didn't work quite the way you expected. There are other reasons why there's problems. You have iron malabsorption. I did a study at the VA. 38% of the vets are on PPIs. Now, I bet you look at your practice, you probably say, yeah, that's about 3 and 8. We're on Protonix, omeprazole, or Losec, or something, acid-reducing drugs. And so these people don't absorb iron well. In fact, some of them don't absorb iron at all, okay? And the way you can tell, if you wanted to, you can do an absorption test. I'm not saying you should do that, because here's the data, okay? So here's the iron level on omeprazole, and this is the iron level after being off omeprazole for 2 months, okay? And this is at 30 minutes, 60 minutes, and 120 minutes after taking a test dose of iron. So your patients who are on PPIs won't absorb iron well. So if they have iron deficiency, you have to think ahead of, well, how do you get around that? Do they need a PPI? All right. And then you have to figure out, okay, how you get around that. Sometimes parental irons, when that's stopping that PPI or reducing the dose, and that's not easy for some patients. But you have to be aware, this is very, very common, because I see it all the time. Okay, if someone is on iron, you should see a response within a month. So even though you might give them 3 months of iron, you should see a response in 4 or 5 weeks. If you don't, then there's problems with your non-compliance, malabsorption, or continual blood loss. That's pretty basic. But the key is, think of PPIs there and understand its role in your therapy for those patients. Parental iron therapy, I think you refer a lot of patients to me because you think they need to be on parental iron and you want to be sure, you need some concurrence on your opinion. And we generally these days use iron sucrose. It's preferred over the cheaper and older iron dextran because its safety profile doesn't require test dose. These people can have vicious infusion reactions. The kind that, you know, they up the pressure to 70 and they're sweaty, they're all out. You know, they end up with a crash team or something in the ER. It makes people really nervous. It makes the nurses really nervous. Okay, so we tend to use Vinifer more now. However, it requires with Vinifer multiple doses to get iron stores up. So we're talking about probably 3 or 4 visits to the outpatient department rather than 1 visit. And And then all of these patients who are in iron therapy have tough problems, and they require long-term follow-up because they're going to get iron deficient again. Every patient with gastric bypass who has parental iron therapy, everyone has got a certain frequency how often they need it. It could be every couple of months, it could be every couple of years. When I retired a brain of a kid who's got a small bowel problem, and I first met him when he was 16, and he's on iron dextran, 2 grams every other week. If I cut it back a little bit, he drops. He got a machinist with a machinist school in Staples. He got a job in the Twin Cities. No one believed him. So he comes back to Brainerd. He still comes back to Brainerd 20 years later, every other week, and get his iron dextran. Because people can't believe that he needs that much iron. But if you cut it back a little bit, he goes from 12 to 9 in 2 or 3 weeks. It's amazing. Everyone's dynamics are a little different. I don't want to think that everyone's like that. Most people are not like that at all, but they can be that extreme. So, summary is absence of clinical bleeding is common in iron deficiency, so you need a careful GI assessment. Look for H. pylori disease, celiac disease, and causes of atrial gastritis. And when I get a chance to interact with Dr. Fleming and the surgeons and the Minnesota GI people, I like to see gastric and duodenal biopsies in everybody because they'll miss it otherwise. Number 2, the distinction between anemia, iron deficiency anemia, and iron anemia chronic disease. Remember that slide about that 1/3 group about serum ferritins and the serum transferrin receptor study? This concept of anemia of aging, so not all myeloanemia in older adults, as you may probably suspect already, is not pathologic. It's something that's related to that thermostat reset that's off. And then the 4th take-home lesson is remember about your PPI patients. If you give them iron, they may not respond. I think that's it, yeah. Any questions? No post-test, so. Thank you.
Doctor?
Yeah.
I don't have a question about this, but I do have a question that maybe you can answer for me. We're being more aggressive about managing sepsis in the emergency department. There's this surviving sepsis campaign, whatever. In patients who are in chemo, I've been told more often than not to start antibiotics once I've cultured people. What is your approach in that regard? Do you think we should be getting people on broad spectrum antibiotics and we culture them if they come in and they have a low white count or maybe a little bit of a fever, not a low white count?
Oh, I think they have to be on empiric antibiotic therapy.
Okay.
I don't think I would not do it. I think the choice of antibiotics is governed by your local culture here. Because the studies have shown there's a variety of regimens you can use for coverage. But that's not your question. Your question is, should you use any antibiotic therapy? I really don't think there's a role for not doing that. Remember, these patients often have implanted ports. It's a foreign device, so they get odd infections from that. And I really can't think of a situation where I would not administer antibiotics to those people.
There have been times when I've talked to hematologists, oncologists who told me not to start antibiotics. That's not what you're thinking of.
No, I think that has to be a minority view. I don't like to talk about cancer problems because that's not usually relevant to primary care providers. You're usually seeing outpatient stuff. I talk about lung cancer and breast cancer. It's interesting, but it's not really relevant. I might talk about screening issues and stuff like that, prevention. But really, my emphasis is on hematology stuff that you see in the office on a